Hey everybody, welcome back to the IMG podcast. I'm your host, Dr. Sammy Khalili, and I am beyond thrilled to have our neuro-ophthalmologist here at IMG, Dr. Brook Johnson, here joining us here today. I'm super excited to talk to her about what led her here into this career field, how she came into both neurology and everything else that she's been doing, what's her passion projects and outside of work. And then on top of that, she's going to talk to us a little bit about headaches today and the kinds of headaches that she sees on a regular basis. So let's get into it. Oh, good to have you here.
Thanks for having me.
Oh my God, my pleasure. We couldn't have been more excited to have you join our team way back when in the last year. No one more obviously than Dr. Winkler, who was on with us last episode. But I kind of want to know a little bit more about you. And I think a lot of people in the region, because you're newer to the team, but at the same time, so many people utilize and need your services. I think they want to know a little bit more about who you are and how you got into this. Like because your trajectory, you correct me if I'm wrong, is a lot of people think that, because you specialize in neuro-ophthalmology, which would mean like, neuro eyes, you'd go and become an eye doctor first and go that way. But that wasn't your career path, correct?
Correct, yeah. Yes. So you can do that. You can be an ophthalmologist and then be a neuro-ophthalmologist. But you can also be a neurologist first. So how I did it is did neurology residency first in Bloomington, Illinois, with at that time called Advocate Broman. Now it's Carl Broman. And then I did my neuro-ophthalmology fellowship at UIC, University of Illinois at Chicago, and then actually stayed on there for 5 years before I came here.
That's awesome. So you were in practice for a bit now. And
a little bit, yeah.
A bit of a seasoned professional now at this stage. So what made you decide to go, because I often ask this to everyone who comes on, what made you decide to become a physician, like as opposed to anything else? Because many of us, if you had an interest that way, you could have gone and done anything, I guess.
Sure.
But
So my dad's an optometrist.
Oh, no way.
Yeah. And I actually have 2 brothers and a sister-in-law who are all optometrists. So lots of eyes in the family. But when I was a junior in high school, my dad was like, I thought I was going to be an optometrist like him.
Now, for the audience, I want to make sure that they understand the difference. An optometrist is a person who specializes in designing, forgive me if I'm saying this too simplistically, but designing glasses for people. Is that correct? Or
glasses, contacts, they don't do surgery.
They don't do surgery.
That's the big difference, I feel like.
That's correct.
Ophthalmologists do medical practice and then they do surgeries a lot of the time.
Right. Okay.
Yeah. My dad, I thought I was going to be an optometrist. I had already chosen to go to Ferris State University, which is the only optometry school in Michigan where I'm from.
No way.
So I thought I was going to be an optometrist. And then he said, well, I want you to shadow my friend who's an ophthalmologist. He said, I love my job. I would never change it, but I think it's cool and I think you should go shadow. So then I went and shadowed his friend. And then I saw one cataract surgery and was like, this is the coolest thing ever. The ophthalmology is amazing. I want to do ophthalmology. But then it turned out I don't really want to be a surgeon. So I took a different path and did neuro-ophthalmology to do the ophthalmology side of the brain.
That's amazing.
Really cool. Yeah.
And so when you were in medical school, did you have a passion at least for neurology itself too?
I really liked the neuro-op stuff.
Yeah.
So I do like some neuro, like headache,
that
we're going to talk about later. A lot of the neuro I don't love as much. So even in my residency, my attendings knew that. And they said, okay, well, I was in a residency program that was fairly new. I was the second class. And they were happy to have me kind of build it how I wanted it. So I did several neuro-ophthalmology rotations as a neurology resident, which actually is not part of the curriculum. You don't have to do neuro-ophthalmology. A lot of neurologists don't even know neuro-ophthalmology is a thing.
Well, that's very true.
Yeah. So in ophthalmology, they have to do neuro-ophthalmology as a rotation when they're in residency, but you don't have to as a neurologist. So I was happy to just go other places. Actually, I went to UIC for a rotation. And I think that's how I got the fellowship, because they knew me and then they knew, how I would work in the practice and things. So it worked out really well.
Absolutely. And with the amount of extra training you had been doing on your own because of how you built a lot of parts of your residency, then you would have been a gold mine for them, because it would have been far less work on their part, all the work that you were doing.
It was really helpful to have my dad too, because even in medical school, I would go and work with him.
Yeah.
And he taught me how to use the slit lamp. So as a neurologist, neuro-ophthalmologist, that's the huge burden you have in residence or in fellowship is to try to figure out how to use all these tools. So I already knew how to use the slit lamp, how to do an eye exam, all that stuff. It was super helpful to have my dad help me, but then also all these neuro-ophthalmology rotations. I, in the rotations as a resident, already kind of knew some things, so they loved it.
That's
So it was
awesome.
helpful.
That's
Yeah.
really, really neat. So when the family gets together, like, do you guys share
Oh
stories?
my gosh, all the eyeball stuff. We literally have a Snapchat that's called ECPs, which is eye care providers, and then we snap like fun stuff or like interesting stories. Yeah,
That's awesome.
yeah.
Any stories that you care to share that you thought were very entertaining in recent
I'm
memory?
trying to think. I've had a lot of my multiple times my brother and my dad have like sent me pictures like, is this papilledema or is this just drusen? What am I looking at? What should I do? I've had them ask me about like double vision patients, like, hey, this is this funny movement. Can I send you a video? Because I don't know exactly what it is, but can you help me? So
That's
it's really
awesome.
cool.
That's
Yeah.
really, really cool. Not everyone has that experience, so that's a fantastic story. Outside of like this world, what do you do outside for fun and things?
Yeah, so I have two babies.
Hmm.
I have a 3.5-year-old and a 1.5-year-old. So
So your time is
busy,
consumed. Yes.
busy, busy, busy.
Yes.
Yes, they always are wanting to do things. My older one's like really into Barbies right now. So she always says, Mommy, make this one's voice. And I have to talk like I'm the little Barbie mom or whatever.
Hmm.
Yeah, it's super fun. My younger one is really into dancing. So we do a
Excellent.
lot of dance parties at home.
Excellent. I
Yeah,
know exactly what that's like. I have three of my own, and it's either continuous dance parties or continuous ridiculousness that's happening all day
yeah,
long.
yeah,
So I
they're so
appreciate
fun.
that. But
Yeah.
like as you say, like it's hard to do much else other than be present and be all the work that you do for sure. So outside of this, in terms of the work, you discovered us, I guess, from the postings we had. We were looking for someone just like you.
Yes.
And what made you change from the academic environment that you were in? Because you were at the University of Illinois in Chicago,
Correct.
not to be confused with the University of Chicago. As a Canadian, it's hard to remember which one's which. But and you had a very successful practice there.
Yes.
What provoked you to come and join us and have fun on this side of the city?
So I'm gonna be honest. One of the big things was when I met with you. You were so engaging and like loved it, and like I tell every single person that interviews that they have to interview with you because it was amazing. But
That's very sweet.
no problem. So one of the big things was my kids are getting to be school age,
Yeah.
and I wanted to come to the suburbs for the schools and for we're going to move at some point. Right now, our house is up for sale,
Hmm.
so we are going to move, get more land.
Hmm.
Just more suburbs are a little bit better. I feel like for raising kids. So that was the biggest thing. I mean, and then when I met with the team and everything,
Hmm.
the amount of support we have here is amazing.
Hmm.
I have my own RN, which is fantastic. She does a bunch of stuff for me that I was doing on my own before. Um, I have LPNs and techs and all these things that we have a lot of support here, so it's great.
Yeah, we give you a lot of time. The team gives you a lot of time to think, right? Like you
Right,
have a huge amount of time to think about the challenging cases that come through. Think about how we best can help the people in the community, and not be focused in on mundane things that we are able to, I guess, better way to say it, outsource it to other individuals to do.
sure, exactly.
Right. Which is great. We're so I can't emphasize how like awesome it has been to have you here, and how much we all feel blessed that you're part of the team.
It's been a great start. I love it.
Yeah. So let's get into now the kind of the big topic that we kind of wanted to talk about, because it's so common. We see a boatload of this in even in my clinic as it comes through as an ENT, but you see a ton.
Hmm.
And so it's headaches, and almost everyone at some point in their life has suffered with some version of a headache. I think the question that a lot of people know is like, when do I need to have this kind of investigated, and who do I go to? Like, where do I start?
Right.
So I think you're a wonderful guide to kind of help with that.
Exactly. So I wanted to talk a little bit about like red flags in headache.
Yeah.
So if you're a young person, you're having trouble seeing the board in school, and then you start getting headaches, maybe you just need your eyes checked.
Hmm.
And then you don't need to see me, you need to see an optometrist or an ophthalmologist to get, a glasses check. But if you're an older person has new headaches, that's always concerning that there's something going on, like something different. If you're over the age of 50, 60, you've never had a headache before, that's more a red flag. We have to look
Mm-hmm.
for something else. But other things you can think of for symptoms wise, um, if you have any neurologic changes. So if you have vision problems is a big thing and where you would need to see me, like blacking out of vision, double vision. If you have like loss of side vision, if you're seeing funny stuff in your vision, sometimes that can just be migraine, but sometimes it can be more concerning, like flashes of light and things like that. Then you need to be checked out.
Mm-hmm.
Um, if you have any other neurologic symptoms like numbness, tingling, weakness, facial droop, something like that, obviously that's more concerning for
Mm-hmm.
something else going on.
Now,
Um,
do these things have to happen with the headache, or are they happening like you get a headache and you have this happen at the same time?
so sometimes people will have migraine with aura
Mm-hmm.
and they can have vision symptoms
Mm-hmm.
with the headache or preceding the headache or outside of the headache.
Mm-hmm.
So it just depends on like the patient. So you kind of have to figure out, you have headaches and you think they're just regular headaches and you don't have any other neurologic symptoms, maybe you can just see your primary care.
Mm-hmm.
But if you're noticing like, hey, I have headaches, but I also have double vision. Hey, I have headaches, but I also have flashy lights in my vision. Hey, I have headaches, but I also have numbness on one leg. Like that's more concerning. We need to
Mm-hmm.
look for other things.
Okay. So, what kinds of headache problems would you say need to be investigated, but don't necessarily need to be seen by someone like yourself?
So, patients who have headaches that are not managed with over the counter medications or like seeing their PCP,
Mm-hmm.
a lot of times PCPs, primary care physicians, are comfortable with certain headache medications. But then if they get to a point where, hey, these things aren't working and I'm not comfortable anymore,
Mm-hmm.
then they'll usually send to general neurology.
Okay.
Yeah. So, general neurology is fine to start with, but if there's any vision symptoms, that's when they usually will come to me.
Come to yourself.
Hmm.
And then, so once that a person's been established, they have headaches, they have vision changes, they come see you. What can they expect? What are you going to end up doing when they come to see you?
So we'll do the whole gamut of testing. So we get vision testing, we get color vision testing, we check the pupils, make sure they look okay. We also usually take a peek in the back of the eyes.
Mm-hmm.
Especially young females who are overweight can sometimes have increased intracranial pressure, and then that
Mm-hmm.
can cause headaches. So we will do pictures of the back of the eye, make sure there's not any swelling of the optic nerves. So that's called
Mm-hmm.
papilledema, and that's something that I deal with.
Mm-hmm.
And we look for things that can cause that, like high pressure inside the head from tumors, from clots, from something called IAH. There's other symptoms that go along with that would be like double vision that we talked about, blacking out of vision. But there's also one other symptom that I didn't talk about, whooshing sound in the ear, pulsed which I'm sure you've seen a lot.
Mm-hmm. I do.
But that can be an indication for high pressure, and that's concerning, needs to be worked up.
Absolutely. Okay. And so when we start doing, like, you start doing the workup for all this, and let's say you discover person, let's start with something simple, like a person you think based on their assessment, their visual changes is not related to anything related to their eyes. It is more truly something like migraine.
Sure.
What happens next?
So, migraine patients, I will make sure they don't have swelling. I will make sure the vision's okay. And then typically, I don't treat migraine because I see too many neuro-ophthalmology
Mm-hmm.
things to keep my migraine under my practice. So then they would see general neurology for migraine management. Sometimes, if they have migraine with aura and it's visual aura,
Mm.
it's still treated the same way, but then it has a vision component. So sometimes I'll treat those people myself, especially if they don't already have a neurologist.
Mm-hmm.
But a lot of times these people are coming from ophthalmology or neurology, so they already have somebody that's managing them.
Mm-hmm.
And then I'll say, hey, good news, there's no swelling, there's nothing wrong with the eye itself. I think this is migraine, and then you can see your
I think
primary neurologist.
I think that's a great bit of information. The reason I brought that one up for the people to know is because, as you probably know, migraine used to be classically defined in one very specific kind of pathway. But then we found, as you know, a whole bunch of people that don't quite fit in that perfect mold,
Sure.
but they're under the umbrella that if you treat them that way, they actually do get better with the same migraine medications or treatments, I could say. And there's just a lot of patients out there who suffer with headaches that we end up finding out that come in and present to me, I know, with atypical facial pain and other things like this that are part of that same umbrella.
Sure.
You see it all the time for a
Eye
variety of things.
pain and
Yeah,
all the things. Yeah.
exactly, exactly. So now let's move on to, let's say it's not migraine, and you discover a young female that is a little bit overweight that does have high brain pressures.
Hmm.
What do we do?
So we have to rule out tumors or clots inside the brain that could be causing the high pressure. So they always get an MRI of the brain, and then also imaging, whether it be MRI or CT, of the venous structures in the head to make sure there's no clots.
Okay, so venous guys meaning veins, just in case that didn't clue in. And what that involves is getting a specific kind of MRI, right? Do you get usually an MRI V, an MRI artery as well, both at the same time, or?
So we don't have to do arteries, usually
Okay,
just the venous system. So
okay,
MRV and then an MRI of the brain.
okay,
Yeah.
great. And then what happens then afterwards?
So then if those things come back normal, we do a spinal tap,
Okay,
a lumbar puncture, where we check the pressure inside the head. And then if it is high, that gives them usually criteria for what's called idiopathic intracranial hypertension. Idiopathic, we don't know why it happens. Intracranial, inside your head, hypertension, high pressure.
yeah.
And then those patients are treated a certain way with different medications.
You realize that most things in medicine are not actually that complicated. We make it a bit more complicated with the words that we use,
Sure.
but it's how we talk to each other. All right, and then so we kind of have a standard treatment for that. Now, let's say it's not one of those things, and it's pulsatile, you know, headaches that people are having that you can hear. What is typically for you the workup as you start?
So pulsatile tinnitus is similar to IIH. We would do the imaging and then also the spinal tap just to see if it's high pressure.
Mm-hmm.
Even if they don't have swelling inside the eyes, I've had patients who have whooshing that end up being high pressure, and then we treat them similarly.
Now, is there any thought in terms of how you investigate this, or whether you're going to how aggressively you investigate these headache problems, depending on the frequency of the person they're having, or does that change your algorithm in any which way? Or?
So yeah, if patients are having headaches all the time and they've tried medications not working, that's somebody that we want to do more urgently. Or if they're older patients, I had actually in this practice,
Mm-hmm.
I had a 70-something-year-old patient who came to me with pulsatile tinnitus.
Mm-hmm.
I said that's not normal. And then usually these patients, if they have IH, are like 20s, 30s,
Yep.
childbearing age females. She was in her 70s and had pulsatile tinnitus, and they correctly sent her to me to make sure she didn't have swelling, and then she had papilledema, and I was like, this doesn't make any sense.
Mm-hmm.
So she ended up having actually a dural AV fistula. So she had this miscommunication between the arteries and the veins in the head that was causing high pressure, that was causing her problems. So then she got a pretty extensive workup and pretty quick, because I said this 70-year-old patient should not be having
this. No.
Yeah.
Yeah, and that's important to note. A lot of people will ignore certain symptoms and kind of say, "Oh, I don't need to kind of go deal with these things." And it's very important to just, if you have a question about it, get help. And the way you start, I think the most appropriate thing is either begin with your primary care or go see a general neurologist, and they can help us figure out what type of version of problem you're having. Would that be correct?
Yes.
But if you're having truly visual issues, you can start with you.
Start with me or start with ophthalmology.
Yeah, one of the two.
It's always good to have. I like to have an ophthalmology dilated exam, because I'm not an ophthalmologist. So I could do a dilated exam and I could say, hey, something looks funny, but I wouldn't know exactly what it is. So I always like to have them say, hey, the eye exam looks normal, then can you step in? And that's really helpful for me.
Yeah. So you can see how a lot of, like, we work a very kind of in tandem all together. We're not siloed to say, hand it off to this mechanic and that mechanic. We're all kind of working all together to figure out the same problem. Well, that's great. Is there anything else you kind of want to tell us, or any other nugget of information that you feel like is important? You've covered a great ground, so I mean, I'm not expecting anything. I'm just more curious.
So one of the things I do see sometimes is patients who come to me because they have abnormal MRI findings. So there are some MRIs that come back and they look like, the radiologist might even put in their IIH, idiopathic intracranial hypertension, because there's certain things that just look a little bit funny on the MRI. And I won't go into detail on what all those things are, but basically, sometimes they'll say that. That's not always, you shouldn't always be super worried about that. Sometimes it can lead us to, develop, see the papilledema, see that they have IIH. But sometimes if a patient comes to me, they're a male in their 60s, I mean, I'm less likely going to assume that this patient has IIH. We'll do the workup.
And IIH, just to reiterate, is idiopathic
intracranial hypertension.
Okay.
So, if you're an older person, if you're male, I mean, it's less likely for you to have this. That's not always true. And we'll do the workup, but a lot of times I get these imaging findings and they're non-specific. It doesn't mean you have this IH. So,
Mm-hmm.
yes, you need to come in and you need to get worked up, but I want people to be aware that sometimes the MRI is just non-specific and it doesn't really mean anything.
Correct. Yeah, this is all great information. And I think at a later date, we'll go into a little bit more of the nitty gritty details for people because I think that some people out there just want to know, just
Sure.
have an idea of what's happening. But it's my pleasure to have you here today. Thank you so much for coming in. This has been
Thank you for having
fantastic.
me. This has been fun.
We have lots more topics we'll talk about together. Some on audio and some in video. We'll see. And I'm sure if you guys have more questions for Dr. Johnson, do not hesitate to ask us. We will use this platform to educate you as much as we possibly can in the best way we possibly can. So don't forget to like us on all our socials and subscribe to our channel. And look forward to seeing you next time.